All right. So that's the model of OCD. That's the diagnostic criteria, what sets them apart. Um, we talked about this a little bit already when we talked about the negative reinforcement cycle, and we talked about little David who threw a fit because he didn't want to go on the bus because he was super anxious, and then mom rescued him and said, "Fine, I'll take you to school anyways." So that idea of family accommodation is very common with anxiety and obsessive compulsive disorders. And a lot of times, as far as OCD is concerned, the caregivers and siblings can be involved in the rituals, either knowingly or knowingly. So a lot of times, like that reassurance seeking. Let's say, I don't know, I'm trying to think of an example off the top of my head, but I think allowing compulsions to happen or being part of them, like, here, don't forget, you're weren't you going to check the thing 6 times? Like, I think things like that, which are not intended to be, I don't think the intent is obviously to maintain the OCD, but things that are really well meaning from the family side can be part of the ritual and can be reinforcing of the behaviors. So, family accommodation, as far as the definition, is any parental response that is directly or indirectly part of the child's OCD symptoms. Direct implies that they're part of it, so they participate or they assist with the rituals. Indirect is modifying the family's lifestyle so that the rituals can then happen. So it's an important target in treatment, especially with kids. Which brings me to a related etiological, physiological condition that's been discussed. So pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection, or PANDAS, um, is something that we hear sometimes coming up when we hear people who are coming in for OCD. You primarily hear about PANDAS in, again, a primary care, like medical setting, a ped setting. So keep that in mind. But there has been some research on the role of environmental influences in the etiology of OCD. And in this case, environmental means like pathogens, like toxic, any toxic agents. This isn't necessarily environment in terms of social environment, like your parents, your family. That's not what we're talking about here. It's like real life. So, in particular, there's been some research on or some discussion about the potential role of infectious agents. And with PANDAS, the idea is that a subset of cases, so a subset of people with OCD, um, have, like, it's the result of this particular disorder called PANDAS. So there's a possible set of OCD cases where that sudden onset of having OCD, so all of a sudden having these obsessions, having these compulsions, and more commonly these tic symptoms, happen after the child contracts strep throat. So this is not like super common. The idea here is that it's not, a lot of times people will say, like, it's not all of these other known risk factors that we talk about. And we always talk about the biological and the environmental in terms of parenting, how we always talk about how those things interact and are usually responsible for mental health problems. Like, there's not one cause. This is a subset where we're saying the OCD symptoms or the tic symptoms are explained by this one organic cause. So that's a word that we used earlier. I don't remember which disorder we were talking about, where organic meaning it's bodily. There's something that happened, like a physiological or a physical ailment, a medical illness that then resulted in these mental health symptoms. Most cases, this is not going to be true. It's going to be some interaction of everything, your temperament, your genetic heritability, or was there a stressor, a precipitating event, right? If we think about the developmental psychopathology model. So in general, that's how we conceptualize most children with OCD. But there's some research saying, okay, there's a small subset of people who have OCD only because of the contracting strep, or have tic symptoms only because they contracted strep. There's the evidence behind this, or not the evidence, the conceptual framework, why people think this is a thing, is because they are rooted in an autoimmune theory, which has pretty mixed and limited evidence. But the idea behind PANDAS being a known etiological factor for OCD is that the OCD symptoms themselves are a result of some sort of autoimmune response that happens in the body because of this strep and the way that it impacts antibodies. Regardless of the cause, the treatment is the same. So I don't care if you walk into the clinic and you say, my child has OCD. Actually, there's a family history of OCD, or my mom, his grandma has anxiety, and it seems like anxiety runs in the family. And, I think I noticed like it's these symptoms really started to flare up when my husband and I got divorced, right? Like I'm kind of naming the things in the developmental psychopathology model. I don't care if you come in for that or if my child had strep throat and I noticed, and we have this anxiety in our family, and perhaps there is a precipitating event, which would be the PANDAS. Um, and so I'm coming to you because my child seems to have tic symptoms or kind of feels like they have OCD. Whatever the reason you're walking into the referral for, the actual treatment for the OCD symptoms is going to be the same. So that's important. It doesn't change the treatment. Presumably, if you're saying the child has come in for PANDAS, it's after the strep infection. They've already treated it. It's over with. So there's no medical intervention necessary. The actual treatment of the OCD is still going to be exposure with response prevention. Okay, so exposure and response prevention, ERP, that's what I'm referring to. That's the evidence-based intervention for OCD, regardless of PANDAS or not. So it's the gold standard treatment in general, but especially for youth. Can be used to treat children, adolescents, and adults. And in general, if we're talking about a circumscribed ERP protocol, it's usually about 12 sessions, 60 to 90 minutes. That's what the research shows. It always does like a very clean manualized version of an intervention. Same thing with CBT for depression. It's usually a very circumscribed amount. And again, in practice, though, this can be extended. So the components of ERP are going to include individual therapy plus family therapy for a child, at least. Individual therapy is providing the child with, or your client with, psychoeducation and treatment planning. So explaining what, number one, explaining what the treatment is going to be. So you always want to say, like, this is the intervention I'm planning to use. It's the evidence-based gold standard intervention. And you're giving psychoeducation about what OCD is. So these are what obsessions are. These are what compulsions are. Does that sound true for you? It sounds like you have blah, blah, blah obsession. It sounds like you're doing this to relieve it. That's a compulsion. So kind of giving psycho ed about symptoms. What is it? Really trying to destigmatize any aspect of that can be really scary. And you're also explaining, like, so, we have this intervention and the way it works is you explain, like, with exposure, this is supposed to help with this, and it's going to be really hard. That's why we avoid it a lot of times, or that's why we do the compulsions. But here's the reason for it. Like, here's the model. So all about providing psychoeducation and treatment planning. Here's what treatment's going to look like. And then you actually do the exposure and response prevention with the individual client in individual therapy. From the family side, when we're incorporating the family, we're also giving them psychoed, and that psychoed might be about family accommodation. Like, here's the model of OCD, here's why we're doing exposures. And actually, it seems like you've been doing this, and I know you mean so well. Actually, when we put this in this model, that actually reinforces it. And you probably didn't know that. So giving psychoed about how that behavior on the family's part needs to be targeted as well. Then there's a disengagement model. So like, how do we help disengage from the family accommodation? And then at the end, review the end of treatment and help consolidate. The overall goal of ERP is to weaken associations between the obsessions and anxiety and between the compulsions and experiencing anxiety relief. So just like the anxiety exposures, over time with these exposures, it's basically kind of like desensitizing yourself, like training yourself that this anxiety can go down, you can tolerate it. ERP is not effective if we don't continue, or this has actually changed a little bit, but in general, the primary belief for many, many, many years, and still currently, is that ERP is not effective if you don't continue the exposure until habituation occurs. So until the distress becomes like nearly null and like it, yeah, and with repetition, like it doesn't induce any anxiety anymore. So you habituate to the stimulus. The other thing is that it believed that if you do not actually target the core fear, it's not going to be effective. So the core fear is the worst possible outcome. I stand by this one too. This is what I said earlier with those anxiety example ladders I showed. We need to be actually treating the underlying fear. So if it's, I don't know, like with anxiety, I said the kid's fear was everyone's going to laugh at me. People are going to judge me. So like all of the exposures we did were designed to potentially elicit that sort of reaction, and it never happened. With this, the core fear might be like, and I'm going to exaggerate, but like if there's a contamination fear, like if I, I don't know, if my hands are dirty, I have germs, like I'm going to get, I'm going to contract a disease and then I'm going to end up in the hospital and then I'm going to die. Something pretty like, intense and extreme and very much snowballing and catastrophizing. So that could be the core fear. I'm going to die. I'm going to get so sick, I'm going to die. Your exposures are really going to target that fear and the compulsion, why the compulsion is happening. The compulsion is happening because I have this fear that if I don't, I'm going to contract a disease and die. So we want to be able to name it and label it and make sure that we're coming back to that core fear when we're talking about it in therapy. The other thing is that ERP will be ineffective if the simultaneous rituals are not prevented. So if there's anything else happening, so not just the compulsions, but like if there's other stuff the person's doing, like we basically consider it a compulsion and we want to target it. So just to be clear too, the exposure itself is helping the patient confront their fears or discomfort related to the obsessional thoughts. The response prevention is having the patient resist performing the compulsion. Keep in mind it's systematic. It's not throw you in the deep end. It's like we're going to spend time doing psycho ed. It's also really important to build rapport. If I have terrible, and I don't, but like if you don't have good rapport with your client, they're not sold on why our ERP is going to be helpful. There's understandably a lot of anxiety and resistance about doing it. You have barely talked to each other. You've only gone, I don't know, had 2 sessions together. Exposure and response prevention is going to be really hard to do. So you also want to make sure like this whole idea that like there's a relationship there and you're walking alongside them, trying to help them through the exposure, and especially the response prevention is really distressing. So that's going to be important. Uh, okay, we talked about this already, but exposures, you develop a hierarchy. The exposure tasks begin with the least most anxiety provoking to the most anxiety provoking. These exposures can be imaginal or in vivo, so we can, depending on how much distress it causes, some people might need to start at imaginal and then work their way up to in vivo, like doing the actual thing that they are scared of. So again, I'm going to use the anxiety example, even though this is OCD, but I made my client, not made, but we like did stuff in the session, like do an impromptu talk right now. Talk for 30 seconds. That's in vivo. Imaginal would have been, can you imagine yourself giving a speech in front of your class? And if that was distressing, then that was a good one to put on the hierarchy. If it was like, nah, I don't really care about that, wouldn't put that on the hierarchy. Here for especially OCD, and sometimes it can feel like there's some things that are hard to test, right? Or they're a little like extreme or like otherworldly, so you can't really do in vivo. Some of those things you're going to have to imaginal. So can you imagine, I don't know, like I can't think of something at the top of my head, but like sometimes people have fears that they're really like obsessions that they're really embarrassed by and they feel really shameful about. So you see that sometimes with like homicidal, but not true homicidal thoughts, just like things like I'm scared that I want to kill someone. I've heard that discussed before too. It's not a true homicidal intention. It's an obsession and it's ego dystonic. There's this fear. We're not going to test that. We're not going to say, ooh, what happens if we start making plans to implement that plan? We're not doing that. It's more imaginal in that case, where it would be inappropriate and unethical to try to do that in vivo during the exposures. So as they're doing the imaginal or in vivo, the therapist is providing support and they're encouraging them to go through it. Like, you got this. They're confronting the feared stimuli, you're modeling, giving instruction, giving them feedback. Yeah, and this is what I said for nonsensical, bizarre, inappropriate obsessions and compulsions. Yeah, you're gonna have to use imaginal. Um, the reason why, if we go back, I kind of laughed at this first one. Number one, ERP will be ineffective if not continue until habituation occurs, is because there's a couple, there's like two camps at this stage now where we used to think habituation had to happen, and there's other explanatory models saying like it actually doesn't have to be habituation, inhibitory learning has to happen. So habituation is the natural decrease in fear that's elicited by the stimulus, so it no longer causes that much anxiety. That's typically the primary goal of anxiety reduction in exposure. That's slightly different from the inhibitory learning model, which is that extinction is maximized when they learn new information that can basically like overpower the original anxiety. So that new information might be learning like, oh, I can get through this, like that cognition of this isn't as bad, this sucks, but this isn't as bad as I thought. Like I'm actually stronger than I thought, or ooh, I used deep breathing. I like didn't think to do that before. Some sort of new information is learned, and that can block out or inhibit the original obsessive thought or urge. So in that case, the goal is to teach that the experience of distress is tolerable rather than aiming to actually just target the anxiety. So the principles are slightly different, and they're both used to explain why ERP is effective. And so depending on which model you subscribe to, you may decide like we're going to continue exposure until habituation, or you might try to dig for, is there anything new that you've learned from each exposure? And that would be more based in the inhibitory learning model. Okay. Medication, this is important because we're have like 1 minute. I'm not going to share this, but this is Eric Storch, who's like a really big researcher in pediatric OCD, and he's here in Baylor College of Medicine, and so very large, prominent researcher in this area. And I think this it's helpful just to see him talk about best OCD treatments for children and adults. As far as medication, SSRIs are most often prescribed, but ERP remains like the top choice, top line treatment. So ERP alone is superior to combined medication plus ERP. A lot of times people try out medication first, but just know that ERP really is the frontline treatment. But if we don't have commitment from the client to be able to do the exposures consistently, then it's going to be hard and it's not going to be effective. So that in that case, an SSRI is usually probably where those people might start.
Now,
Okay. Weekly to-do list, read this week's chapter. I'm going to quickly, we have like 3 minutes. I'm going to pull up our assignment. As I'm doing that, any questions about OCD? No? Okay, really quick. So if you choose to do today's assignment 3, which is due on Sunday, you're watching a video, just kind of like assignment 2, and you're answering these questions. It gives you timestamps. So whatever's in that timestamp, the question is related to that timestamp. Something that I've gotten questions about, and I'll just say this worksheet's all about OCD and a little bit about pandas. So the question that I've been getting that I think is reasonable is this point right here. So in this part of the video, I believe like the parents are talking, you'll see it and it'll make sense. The parents are talking to the provider about their concerns. And this is where I've gotten some questions. How do I answer this? So what do you mean by list aspects of an abnormal behavior that the parents' concerns are speaking to? Justify how each aspect is applicable from using the video evidence. So basically, there's 3 things here that we consider an atypical or abnormal behavior. We always look at like, the atypicality, like is it normal behavior? Is it normative to be doing whatever the child is doing? So that's one thing. Is it harmful slash distressing to the person, or is it causing impairment in the person's life? So is it causing occupational, social, academic impairment? And then is it developmentally appropriate or inappropriate, which is what we consider as child-psyched people. So is this normative given the child's age range? So all you really need to do, and honestly, I would even, if you're writing in paragraphs, that's like totally fine. For this one, you could even say like typical spoiler, there are aspects of each one of these that you can speak to. So you could probably like put here, like, yes, I see atypical behavior, list what it is based on the parent's concerns. So the parent's concerns about, I don't know, coughing, or like these thoughts about coughing repeatedly will cause him to die. That's atypical behavior. What parents are speaking to is atypicality that rises to the level of abnormal behavior. As far as harmful slash negative, just the impairing, the parents are pointing out that the child is being bullied, the child is uncomfortable all the time. This is negative impairment or interfering with functioning. So, like, whatever the parents say that you observed from the video, put that there. Developmentally appropriate, think about the child's age, if they say it, or just you can tell the kid's not like a baby. So, is this appropriate for the child's age and or given his school year? I don't think they tell you what like grade he is in school. It's not developmentally appropriate. So you're basically just listing like, yes, I see these three things of abnormal behavior that we've discussed in class. Here are examples of it based on what the parents are saying. Does that make sense? Stop sharing for a sec. Yeah, okay. All right. If no other questions, I just want to make sure there's no other questions on the assignment because there's everyone here. No. Okay. Well, that was a good question. Sorry it was unclear. But yeah, if you choose to do it, it's due Sunday, and I would use this OCD section of the reading and the pandas slides from this lecture to help you answer. All right, see you guys Monday.